an amazing surgeon, a colleague, a friend, a brother from another country. And thanks for the invitation and to trust Ophthalmology University to be part of this amazing activity. There is so many institutions that are involved. HOB, Harvard Eye with Dr. Robert Pineda. It's just a pleasure to have you here. We have Dr. Cheng Xu from Ayer in China. Imagine, a big chain in China, bringing us so many knowledge. We have Julio Ortega from Clínicas Baviera in Spain. Thank you, Julio, for being here with us. Walter Nose, Takashi, Jonathan, and Guido from Brazil. Such an amazing country, amazing surgeons. Guido from SEMA, too, an amazing center there with so many surgeries. So thank you, everybody, for being here with us. I'm going to do a very quick introduction. We are in so many social media to give a lot of teaching and knowledge of Ophthalmology University and Faco mentors. You can find those social media in Instagram, Twitter, YouTube, Facebook, in all of them, with amazing knowledge for you to become a better surgeon. We're right here transmitting from the Ophthalmology University campus. If I do like that, you're going to see one of our students, in a simulator, training to become better surgeons. And well, we like this phrase and this idea of creating the future of ophthalmology today, to look into the future, to grab technology, become better surgeons, to upgrade also our own software, and be a better in making decisions and problem solving in surgery. And I think that's exactly what we're going to do today, where you're going to see excellence, you're going to see great surgeons. So I ask you to ask yourself that question: what is a great surgeon? What is an excellent surgeon? And for that, I think we're going to learn a lot about our colleagues, but I want you to look about these three important areas. Great or expert surgeons have repeatability, can manage complex cases, and can solve complications. I think those are three very important areas that every single excellent surgeon should be trained on. This is a specific field. We need a lot of knowledge. And when we talk about experience, remember, you are somebody who is able to do some pattern recognition. And when you do that pattern recognition, you need to be good at decision-making and problem solving. So we're going to have an amazing lecture, and we're going to have live surgeries, and your job is to ask us in the chat or everywhere, to learn from these amazing surgeons. So it's my pleasure now to introduce Dr. Julio Ortega from Spain, that is going to give us an amazing lecture. Julio, thank you for being here with us.
Okay, thank you so much for your kind invitation, Ivo and Takashi. It's my pleasure being here in such an amazing meeting with these amazing colleagues. And well, I'm the overseas medical director of Clínica Baviera, which is a group of clinics in Europe. And we are now part of the IRI Hospital Group, which is the largest ophthalmic group in the world, with the headquarters in China. I work in the city of Bilbao, Spain, and I don't have any actual or potential conflict of interest in relation to this presentation. So we're going to talk today about trifocal IOLs in special situations. Well, we know that trifocal IOLs achieve high levels of spectral independence and patient satisfaction after Faco. And we know that because we conducted a study that we published 4 years ago in the American Journal of Ophthalmology on more than 10,000 eyes. And our results were quite good. So, well, because of that, we started operating on more complex cases, some controversial cases. Well, we will talk today about three papers that we have published recently this year. The first one is in American Journal of Ophthalmology in March, trifocal IOLs in emmetropic presbyopes. The second one was published in August, which is trifocal IOLs in patients younger than 40 years old. And the last one was published this month in October in the Journal of Cataract and Refractive Surgery, and it's trifocal IOLs after LASIK. Well, but what about the first paper? Well, we think that an emmetropic patient is someone who has an spherical equivalent from minus 0.25 to plus 0.50 with a cylinder up to 0.75. The age should be presbyopic, of course, from 46 to 60. And we want just refractive lens exchange. So uncorrected distance visual acuity pre-op, higher than 0.9 decimal in each eye. So we did two groups. One group was patients that underwent surgery in just one eye, and group two, both eyes. And all the patients received the Physio Micro Fine Vision trifocal IOL. Well, the results in terms of visual results were quite similar in group one and group two. I mean, sphere, cylinder, spherical equivalent, or distant visual acuity. But regarding binocular and corrected intermediate visual acuity and binocular and corrected near visual acuity, we had better results when we operate on both eyes. Although just when we were talking about near visual acuity, we had statistically significant differences. What about visual disturbances? Well, as we presumed, night problems, night driving problems were more important when we operated on both eyes, although the results were not statistically different. Well, patient satisfaction was the same when we operated on one eye or two eyes. So it's up to you. You can choose one eye or two eyes, and your patients can be very happy if you do that. Well, the second paper we published some months ago, it's very controversial. I mean, we are operating on patients who are younger than 40 years old. But what happens when you have someone with a high hyperopia? They cannot undergo LASIK surgery, and they usually have a narrow anterior chamber, so they cannot undergo ICL surgery. So what can we do? Well, they can continue with their contact lenses or spectacles, or maybe we can have refractive lens exchange. That's what we did. We compared two groups of 133 patients each, operated on binocularly. The group one was patients younger than 40, and the control group was patients older than 50. Well, visual results were really good in group one as well as in group two. So there weren't really important differences between groups. There weren't differences in predictability, safety index, or efficacy index. We thought that maybe subjective satisfaction could be better in older patients because they already lost accommodation. But the reality is that we didn't find any differences in subjective satisfaction between the younger group and the older group. So I mean, well, we have something for these patients. The third paper is something that we will face more and more in the near future. So we are going to have patients that underwent LASIK in the past. So what can we do for them? Can we implant multifocal IOL? Well, we conducted a study on refractive lens exchange or cataract surgery. Patients that had corrected distance visual acuity better than 0.3 decimal. And we had two groups. The first one after myopic LASIK PRK, and the second group after hyperopic LASIK PRK. You see that we had many patients there. And we implanted three IOLs, the Physio Micro Fine Vision, the PODEF, and the Zeiss trifocal IOL. Well, if we look at the post-op spherical equivalent, we can see that maybe we have better results in terms of post-op spherical equivalent in the hyperopic group than in the myopic group. But if we look at the post-op corrected distance visual acuity, we see that we have better results in the myopic group than in the hyperopic group. And we split both groups into two subgroups, depending on low myopia, high myopia, low hyperopia, high hyperopia. And we see that there weren't differences in the between subgroups in the myopic patients. But when we talk about hyperopic patients, well, low hyperopia achieved better results than high hyperopia. In conclusion, we found worse predictability in patients after myopic LASIK PRK than after hyperopic surgery. And after hyperopic surgery, we had worse corrected distance visual acuity and worse safety, more patients losing more than one line. Both groups had similar uncorrected distance visual acuity and corrected near visual acuity and similar efficacy. I just want to show you that this week we have a new paper accepted in the JCRS. It's patients with triple procedure. This is LASIK, then trifocal, and then an enhancement by PRK on the flap. If you want to know the results, you have to invite me again to be with you. So thank you very much. Muito obrigado. And we have a great discussion ahead.
Yes, can everybody hear me?
Yes.
I really love the presentation here, Julio. This was fantastic. I think after all we've evolved in the surgery, I think this is not the next step, but our current step right now. It's great to see the rhythm of publication here. Roberto, straight from Boston.
Yes.
What are your comments on?
No, I think these are really important studies. With the use of trifocal IOLs, of course, everyone is excited to be able to offer this technology to their patients. But, there's we need to understand the criteria and guidelines, who's going to do well with these lenses and who we should avoid using these lenses in. And studies like this provide a very good framework for that. Julio, I'm looking forward to seeing an algorithm from you on how to use these lenses and what you've isolated these very important groups of patients. And I think of course the study looking at LASIK after LASIK is very important, and looking at hyperopes and myopes. They're very different groups of patients. They have very different responses to these lenses, and understanding issues around predictability. I'm curious, did you use any kind of intraoperative aberrometry for those cases? Where Aura used in
Sorry, Roberto. Yes, what we do now is, we only check when we implant trifocal IOL in these patients. Of course, aberrometry is very important. You should take a look at the topography, and you must see that the treatment was well centered, that you don't have high order aberrations.
Yes.
Your patient must be a normal LASIK or PRK patients. You cannot operate on strange patients. So
Yes.
you need good visual acuity. Normal people. That's what we operate on.
Yes.
Then, in terms of spherical aberration, of course, you will have very high spherical aberration in myopic patients, and a very low and even positive spherical aberration in post-hyperopic patients. So what we are studying now is using different trifocal technology in these patients. So if you use fine vision or a Zeiss IOL, these lenses are spheric lenses with minus spherical aberration. So, that's a good thing when you have a high spherical aberration. So these lenses, fine vision, for example, or eyes, can be good lenses if you have a myopic patient, a post-myopic patient, sorry. But what about hyperopic patients? We don't want to lower the spherical aberration more and more. So we are using the Rayner Ray 1 trifocal IOL, which is a spheric IOL, but with a 0 spherical aberration. So this is another study we are conducting nowadays, and we have already presented in the ESCRS Congress, and I hope we can publish the results soon. I mean, yeah. So we're doing some research on the field, you know.
Well, certainly, I think using these lenses for refractive lens exchange is very useful. It gives patients a wider range of vision and spectacle independence, as you pointed out in the study, and satisfaction rate was very high. And I think this is an excellent group to target with this new technology. I think, and those patients who, in general, when patients are under 40 or under 50 in their myopic, we typically don't recommend refractive lens exchange because of the risk of retinal detachment and other, retinal related issues. But for hyperopes, as you pointed out in your study, I mean, this is a group that should be targeted, that can have excellent outcomes. I think we just have to remember, if hyperopic patients who have had hyperopic refractive surgery, maybe not the best patients for some of these lenses, but for hyperopes looking for younger hyperopes looking for a refractive lens exchange, I think your study very nicely points out how this can be used very effectively in this group of patients.
Yes, because we must know that young hyperopes with narrow anterior chamber, they will have a narrower anterior chamber in some years because the lens crystalline is going to grow in the future. So these patients are at very high risk of an angle closure glaucoma. So we are not just doing refractive lens exchange, but also we are preventing them from having angle closure glaucoma in the future.
Yes, no, I think it's very important. Obviously, the pseudophakic lens is only about 20 or 25% the thickness of the native lens. So of course there are benefits related to angle closure glaucoma prevention, and a trend, I think, for doing early lens removal in these group of patients because of the dual benefit, both refractive and glaucoma prevention.
Totally agree with you. I totally agree with you.
Oh, excellent.
Yeah.
Excellent
Other
discussion.
questions from panelists?
Yeah, I would call Dr. Guido Aquino from SEMA Hospital. He works in one of the largest ophthalmology hospital in São Paulo. Guido, please.
Hello, everyone. Hi, Dr. Roberto.
Yes.
Hi, Dr. Julio.
Hi.
First
Hello.
of all, I would like to thank Takashi for the invitation and Ivo for the organization of the Ophthalmo University. Dr. Pineda, I would like to ask you your experience with the wavefront IOL, because I think we have a new technology for these cases with the patients. They had the refractive surgery, and now we need to organize these eyes. Can I talk like this? And I think Vivity IOL, I think it's a good IOL to these patients. What do you think?
So both Vivity, I think, which at least came out in the US about a year and a half ago, and then we also have the iHance from Johnson & Johnson, which is also an extended depth of focus, but on a much lower scale. I've been very impressed with the Vivity as an extended depth of focus lens in a wide variety of patients. It does have some advantages in terms of reduced glare halos at night. It does impact. It does have some impact on the modulation transfer function, so that there is some contrast loss, but not nearly as much as the standard trifocal. And I think this has a much wider acceptability across cases where maybe trifocals weren't as well had as good of outcomes, like some of the post-refractive cases. I've certainly used them in a number of post-refractive, not hyperopic, but definitely myopic post-refractive patients, in patients with maybe more mild glaucoma. The same way we use the iHance. iHance has almost become the standard lens for a lot of people here, instead as a monofocal lens, and certainly does not have the stringent requirements that the trifocals have. So again, these lenses don't provide the fullest range of spectacle independence, but they provide a very wide range of acceptability for the patient. So we don't hear patients complaining about halo or glare at night. We don't hear them talking about so much about the quality of the vision not being as sharp, or they seem to overall enjoy it. And you can do a little blended vision and give patients a very good result. So we've been overall pleased with the technology. I do think that they're in some ways Panoptics had come out slightly before this, but many people are gravitating to Vivity over Panoptics, since in the US we don't have access to the Acrolisa or the Viz IOL. So we have more limited IOL options than in Europe. But Panoptics works well. I think if people really want reading vision, I focus on that. But for distance intermediate and glancing near vision, the Vivity has been really a nice addition to our options we can offer patients. Good.
Do you have any comment, Dr. Julio?
Well, I mean, in our institution, we are using these different IOLs, and we think that they are very different technologies. I mean, one thing is the what we call Monofoco Plus. The Monofoco Plus is the iHance, for example, or the ISOPure. These are monofocal IOLs with no glares, no halos, because they don't have the rings on the surface of the lens. So it's a ring lens, ring-free IOL.
Yes.
Then we have what we call the real EDOF IOLs, which could be with rings or without rings. So without rings, we have the Vivity or the Lucidis, and these lenses are very special lenses. They have something called XCIX in the center of the IOL. So I'm not sure whether these lenses are really free of night disturbances. I'm not sure. And then finally, we have the EDOF lenses with rings. I don't understand these lenses really. I mean, if you want rings, you have the trifocal technology. So if you want EDOF, I don't see the need of rings. You want rings? Okay, go for trifocal. You don't want rings? Go for the Monofoco Plus or the monofocal with the XCIX. So that's what we think. We are using all these lenses in our institution We don't have conclusions yet, but let's see. I mean, with the Monofoco Plus or the VVT, for example, we don't have good near visual acuity. They need glasses for near. I mean, okay, it's not like a monofocal, but we'll see. So, but we have many different patients, so we have different options here, you know.
Okay, guys, we have to go on. Now we have to present the case of Dr. Walton. He is already ready. So we're gonna present the case in Portuguese, but it will be translated in English. If you press on the signal here, language, it changes the language in translation. Okay, let's see here. Okay.
Does it have any audio, Takashi?
It doesn't have audio. Can't you hear the audio?
No.
No audio. Oh,
No audio.
okay. I'll pass there. I'll show the case here. So it's can you hear me?
Yes.
Okay, so it's a Caucasian patient with a female with a progressive loss of vision, and uncorrected vision acuity is 20/40, 20/30. She complains of blurred vision, and she's a lawyer. So this is the picture of her cataract, 2+, right? So all the other exams are unremarkable. Topography, microscopy, all unremarkable. This is the Pentagon showing the 1.9 astigmatis diopter and posterior of 0.5 diopter. This is left eye. Today we'll be performing the right eye. So this is the microscopy, the retina exam, OCT, everything are unremarkable. So the biometry, we use the Barrett calculator to see the spherical value, and we did the Alcon online toric calculator. So we're separating 24.5 diopters, Panoptics 40, TFNT 40. But this patient, we're gonna perform aura. Doctor will be performing aura. So let's go to the case then. Ready, Dr. Walton? How is it? Yeah, so Dr.
Faco Clube. Thank you for the invitation, Takashi, and also the Brasília Faco Clube. We have a nice discussion with Pineda and Guido. So I also I'd like to thank Pineda to participate in this discussion directly from Boston. Our friend Pineda,
Yes.
that everybody knows. And Guido, thank you also, and congratulations for all the lectures we had before.
Hello, Dr. Walton.
I'm going to talk in Portuguese now, because I know that there is a translation from Spanish and English to Portuguese and vice versa. So I'll be talking in Portuguese, okay? Bom, obrigado a todos pelo convite, parabéns aqui a HOB e a OPT pela estrutura e pela organização. agradecer mais uma vez o Takashi, o Jonathan e todo o grupo que participam aqui, e o Faco Clube de Brasília, que acho que é a terceira vez que eu venho, que é o maior prazer, e eles são realmente muito unidos e fazem tudo pela ciência e para a melhoria das cirurgias de catarata no Brasil e no exterior. Nós começamos com o laser, então o laser já foi feito, a incisão tem 2.4 por 2.5 internamente para a centese. O que a gente faz um pouquinho diferente é a abertura 0,180. Vocês veem que a pupila já está fechando um pouquinho, mas eu vou pôr, então, a gente usa aqui o Duovisc. Pelo que parece, a Rex está free floating. Então, acho que não vai ter nenhuma dificuldade em tirar a Rex. Vocês podem ver que ela já está solta. Agora, normalmente, antes de fazer a hidrodissecção, eu já tiro um pouco do viscoelástico para tentar liberar a bolha de gás que o laser produz, para não aumentar a pressão dentro do saco capsular. Vocês veem que é um cristalino relativamente mole, como foi apresentado, né? Um paciente de praticamente 50 e poucos anos. E agora nós vamos fazer a hidrodissecção. E vamos para a facoemulsificação. Os parâmetros estão na tela? Não. Não. Vídeo eu violei. Acho que a gente pode ir comentando.
Yeah, I just a comment. I mean, I think this is, the femto technology is so flexible because there's many different patterns you can make with the laser to remove different types of cataracts. Takashi, do you want me to comment?
Yeah, please comment.
Okay, sorry. Yeah, so yeah, no, I think what Dr. Volton is showing here is how effective the laser is at dividing the nucleus, and as I mentioned before, many different patterns. I use a similar pattern, a cylinder with the cross to break up the nucleus. It doesn't take as long as sometimes developing the cubes. People can sometimes pre-chop or use this devices to liberate some of the gas. And, and shown here, Dr. Volton was easily able to remove the capsule rhexis and perform the hydrodissection with the quadrant removal. And you can see sometimes the cortex in these cases, it's a little more adherent. It's a little harder to strip off. They normally recommend a tangential technique to remove residual cortex as opposed to more traditional stripping technique that some people do. I pretty much do tangential stripping for everything now. But you see how nicely the rhexis is, and again, you can adjust that in many different situations. And I think there was just a recent paper out showing that the refractive outcomes were slightly better with femtosecond laser, using a femtosecond laser as opposed to a standard, capsule rhexis. But I think go ahead.
Isso que o Dr. Pineda, que o Pineda comentou é importante. O Jonathan aqui o grupo todo, eles fizeram a Second Wave como publicação, que nesse caso, essa massa que está embaixo da cápsula sairia com uma própria segunda colocação de líquido, como se fosse uma nova hidrodissecção. Seria o Second Wave que facilita isso que o Pineda acabou de comentar. Então, aqui, às vezes, fica realmente essas massinhas e a gente tem que ir retirando lentamente.
Dr. Walter? Dr. Walter?
Pode falar.
Queria perguntar para o senhor o seguinte, às vezes, essa catarata não, porque ela é um pouquinho mais mole, né? Uma catarata mais molinha. Mas, em alguns casos, uma N3 para cima, eu reparo que quando a gente faz o fento, fica uma fibrose na cápsula. O senhor tem notado isso ou não?
Fibrose não, ela tem essa dificuldade de tirar as massas, eu diria. E ficam essas fibrazinhas, que às vezes eu dou esses beijos na cápsula posterior para liberar essas fibras. Isso que eu acho que o fento às vezes... Ah, tá vendo? Parecia que não tinha mais nada, sempre tem um pouquinho de resíduo. Acho que isso faz diferença, sim. Agora nós vamos, então, passar para o hora, né? O hora vai ser feita a medida do hora, para a gente poder aí implantar a lente. Então, estou pondo para o VISC, tentar não deixar nenhuma bolha de ar. O tonômetro está na mesa? Então, a gente mede a pressão, né, para ver se tira o viscoelástico que eu pus sobre a córnea também. A pressão deve estar praticamente normal, mas eu vou... Enquanto aguardo o tonômetro, eu vou lavar aqui. Tem uma esponjinha para cotonete. Eu costumo lavar a córnea um pouquinho para tirar o viscoelástico que está sobre a córnea para... Vai fazer a primeira medida, independente do... A gente tem duas marquinhas aqui na córnea, né? Uma aqui e outra aqui. Dá para ver bem. Então, põe o primeiro retículo. Tem.
I think
Agora
Aura is
subiu muito.
very impressive technology. It's really come a long ways, and I think it's become very valuable in verifying our calculations, particularly for toric lenses and post-refractive cases.
Bateu 24,5. T2, né? Faz mais um. T3, né? Peraí. Não chegou.
And Noé Rivera is asking here on the chat for the panel on the surgeons to perform routine polishing of the cells of the posterior aspect of, or what about the anterior capsule? What about Dr. Pineda, Dr. Valton?
I mean, certainly for me, I do both posterior and anterior lens removal as part of routine kind of polishing. But certainly in straightforward cases, obviously, if there's more delicate or complicated cases, sometimes I'm not quite as aggressive in removing everything. But I don't know there's a final final conclusion on this, but I think this is an area that requires more study, and anyone who can figure out how to prevent
Acho que pode abrir a
PCO
lente, né?
will be better for
T3, né? T4. T4, T3. Tá ótimo. Tá. Então, o Hora deu uma T3 para ficar 0,26 a 180 e 168 e uma T4 para ficar 0,25 a 78 o eixo. Então, a lente escolhida era uma 24,5 T4, né? Foi o que bateu. Eles conseguem ver o Hora aqui? Então, ó, vamos pôr a lente, dá para ver, né? A lente escolhida.
Dr. Pineda?
This is where I think Aura is pretty, is impressive, because even with the formulas, toric formulas we have, Aura takes into account not only anterior curvature or toricity, it takes in posterior toricity, it takes in a surgeon and induced astigmatism from incisions, and can help achieve the most accurate alignment for the patient.
Dr. Pineda, I think the Dr. Walton, he always performed the surgery with the incisions 0, 100, and 180. Okay. Do you think that when we change the incision, we will have a better result? Do you think, because he always performed the same place, the incisions,
I think the benefit of operating at the same place is you're surgically induced astigmatism. If you change it all the time, that number might change. Obviously it changes with the eyes, but if you always put it the same place, I think you always have the ability to calculate a little more accurately what you might induce. If you're using Aura, it doesn't matter, because Aura will compensate for that when you measure your toric alignment. So I think if you don't have access to to Aura, maybe learning your surgically induced astigmatism might be helpful for placement of toric lenses to make it a little more accurate.
Retículo. Não estou ouvindo o pessoal. Estão falando? Não?
Sim, estamos escutando.
Então, está praticamente lá, a gente precisa...
Falamos sim, doutor. A gente estava comentando das decisões a 0,180. Perguntei para o doutor Pineda.
Fala alguma coisa aí, Takashi. Está um pouquinho baixo. Não estou ouvindo.
Eu falei com o doutor Pineda, doutor Walton, que o senhor sempre era a 0,180, né? As incisões. Qualquer cirurgia do senhor é 0,180. E eu estava comentando com ele se ele achava que mudar a incisão, porque às vezes a calculadora pede para a gente mudar a incisão, né? E ele disse que o ideal é nunca mudar a incisão, sempre manter as incisões na mesma posição, né?
Eu acho que a parte cirúrgica é a mais importante, né? Você tem que colocar as suas incisões sempre na mesma posição para você fazer a melhor cirurgia possível. E a lente tem que corrigir não só a sua indução do astigmatismo induzido da própria cirurgia, como o astigmatismo do paciente. Então, deixa para a lente resolver esse problema. Cadê o eixo, exato? A marca do eixo. Não, qual dos dois que é? Esse?
Let me call Daniel Moon. Daniel Moon, are you there?
Já, né? Só um pouquinho.
Yes,
Daniel-
Takashi, I'm here.
I have some comments.
Pode molhar a corda um pouquinho.
A very beautiful surgery from Dr. Walton, as always. And Dr. Pineda already said a lot of things. And it's really important the use of OR in this case because we don't have to worry about our incision induction of astigmatism because or you read it in live and compensate the variations of position or individual cases. So we have a more precise indication of a special lens in a special case.
Daniel Scarabotolo, any comments? Dr. Alípio,
Hi. Hey, Takashi.
Olha na luz um pouquinho. Eu não estou vendo. Ah, tá. Levantar o foco. Tá, pode virar. Agora olhar o centro. Olha na luz. Espera. Olha a córnea para mim.
Alípio, Daniel, se vocês quiserem comentar em português.
Just great, really. I got here late, so but it's fantastic.
Estava 0,2. Deixa.
We have another.
A medida final ficou 0,2 de cilindro. Uma das medidas. Agora ela mexe, o olho roda, mais esférico 0,29 e NRR está ótimo. Vocês põem Vigamox ou cefuroxime no olho, normalmente? Vocês não? Não sei, acho que se vocês quiserem comentar sobre o antibiótico, Pineda, do you use cefuroxime or Vigamox at the end of the case? Vamos. Cadê ele? Então, acho que foi ótima a sua cirurgia, viu? Meus parabéns, está tudo perfeitinho. A lente trifocal tórica na posição. Boa recuperação para você.
Yeah, beautiful surgery, Dr. Walton.
Thank you, Roberto. And I was asking if you use Vigamox or cefuroxime at the end of the surgery.
Yeah, so my standard, I have gone to dropless cataract surgery for routine cases. So I inject 0.1 cc's of undiluted Vigamox into the anterior chamber. And then I give 8 to 12 milligrams of triamcinolone subconjunctivally in the inferonasal corner, about 5 millimeters or more further from the limbus. And I've been doing that pretty regularly for about 2.5 years for routine patients. And, you know, patients love it. They don't need to take, I mean, occasionally I'll put someone on a non-steroidal drop, but they don't take any eye drops. And, you know, they tell all their friends that they don't need eye drops after cataract surgery. And it makes them very happy that their friends are jealous that their friends need to take eye drops, but they didn't. So that's become my standard now for routine cases, and where there's no risk of, for select patients at least.
Dr. Walter, tem uma pergunta aqui de qual importância que o senhor dá para a face posterior da córnea nas lentes tóricas, né? E se o senhor usa algum normograma e qual seria a fórmula de preferência? Nomograma.
Ele falou comigo?
Pode repetir a pergunta.
Tem uma pergunta aqui no chat do Noé. Ele está perguntando se o senhor dá alguma importância para a face posterior da córnea quando vai implantar lente tórica, se o senhor usa um nomograma e qual a fórmula de preferência.
Não, a gente usa muito a Higgs e a Barrett. Então, eu acho que, principalmente nos pós-refrativa, né? Então, essas trucadas, tudo isso, o resultado tem sido muito bom. A gente deixa para a fórmula resolver. Não tem um nomograma específico que a gente use, não.
E a face posterior da córnea, o senhor dá alguma importância?
É importante, mas não tem uma conclusão, uma certeza de previsibilidade. Então, acho que isso aí está sendo utilizado direto nas fórmulas. A gente, lógico que olha, mas não tem muito o que mudar. Lógico, o astigmatismo, tudo isso está na Barrett, né? Já está... Não é uma coisa que é direta pela curvatura da córnea que eu vou colocar alguma coisa diferente do que essas fórmulas já desenhadas para isso.
Linda cirurgia, parabéns.
Obrigado. A cirurgia é muito tranquila, porque era um cristalino mole, uma rex boa, pupila bem dilatada, anestesia, sedação adequada, paciente super amiga do Takashi. Conversei com ela aqui na lanchonete na tarde. Então, é diferente, né? Até eu fico meio quieto, porque às vezes você está operando paciente que não é seu e realmente não é bom muita conversa. Às vezes eles não estão nem acostumados com sua voz e às vezes assusta. Então, ela foi super
primeira dama, não.
Não entendi.
Não era a primeira dama, não, né?
Não. Mas é uma pessoa super chegada neles também.
E aí, Jonathan, tudo bem?
Tudo jóia? Tudo tranquilo?
Tudo bem, você? Tudo ótimo. Parabéns aí pela organização, viu?
Aqui está muito...
Any question? Any comment?
Sabe o que é interessante? Quando a gente acaba a cirurgia, né? Nós falamos que foi tudo bem. Lente no saco capsular, o alinhamento e todas essas coisas, né? E a gente usa o HORA para ver se... conferir. A gente usa muito aqui para alinhar a lente, né? Então, no caso de lentes históricas, nós temos a nossa programação inicial, aí o HORA serve para nos guiar durante a cirurgia. Mas aí, quando você saiu, e aí a gente sabe que acertou na mosca, no esférico, no cilindro, dá para falar que a paciente vai enxergar, né?
Dá.
Mas, com todos os cuidados da recuperação.
Vai depender um pouquinho da posição da lente, né? Se ela vai movimentar dentro do saco. Normalmente, o resultado é bem parecido com o que dá aqui no cilindro e no pós-operatório. Mas tem todas essas variações. Uma coisa interessante é que a gente também usa o HORA para reposicionar lentes que saíram do eixo. Não sei se você já usado bastante. Pineda talvez use, você, Guido. Você reposiciona a lente através do HORA. Então, é muito mais tranquilo. E outro caso interessante que a gente teve, catarata total bilateral, nenhum biômetro conseguia fazer a biometria,
fizemos ultrassom para ver se a retina estava boa, fizemos a imersão com biometria ultrassônica com imersão, e sempre se fica aquela dúvida, o paciente era relativamente jovem, será que valeria a pena pôr uma lente multifocal? E sem uma biometria bem adequada, bem precisa, como eu vou fazer? E aí a gente usou o HORA e conseguiu ter um resultado bom, e realmente a biometria ultrassônica com imersão, quem está acostumado, o resultado é bem confiável até. Mas é um outro caso que eu acho que o HORA é importante, né?
É um equipamento de extrema importância nesses casos. Uma curiosidade, eu não tenho, doutor Walter, eu não tenho aqui, infelizmente eu não tenho o HORA, e eu ainda estou usando o astigmatismo fix, né, que é a ferramenta que eu uso para... Mas eu tenho uma curiosidade, como que funciona para a gente, por exemplo, se tiver que trocar uma lente no intraoperatório, a gente programou, não sei, uma 22, uma T3, e se der pode ser muita diferença, né? Mas uma 21, T4, como que funciona isso? Vocês a empresa deixa todo o leque de lente para vocês? Como que funciona?
Acho que é igual para vocês, né? Tem um limite de lentes, e quando você está muito fora do que tem no seu estoque, você pede pelo menos uma ou duas para baixo e para cima. Então, pelo menos umas 3 lentes você vai ter ali. Um T para baixo, um T para cima, e o meio grau de cada uma, 5 lentes. Vai. Não sei se o doutor Pineda quer comentar alguma coisa sobre essa variação, porque você mede antes e vê se bateu. Que poderia ser colocado uma T3 ou uma T4. Uma sobrava 0,26 a favor, 0,20. Então, você, entendeu? Poderia ser a T2, ela ia ficar feliz também.
Yeah. So well, Walton, I'm not sure I quite understood what you were asking me to comment on about the aura. Was there?
If you have the whole range of intraocular lens in your office, for if you change the lens inside of the OR.
Yes, yeah, and we usually bring in the power above and power below. We have libraries of different lenses at the hospital that allow us that luxury to be able to go up or down. And the same with the toric lenses, except for the very high powers. Those we have to special order. But yes, this is always a challenge, because if you have to go to from a T3 to a T4, and you don't have that power, it's a problem. But usually the companies will send us several different versions of the lens if we suspect that, and usually for toric cases, that's the case. I think with the use of the Barrett toric calculator, the percentage of time that you're being off is decreased over time. And even on the Alcon toric calculator, it gives you 2 options. It gives you the Barrett toric, and it also gives you the Holiday. Most people don't use the Holiday, but it requires some additional information. I don't have enough experience with using that formula, but it's something that I think you can actually get a little more precise measurement of the toricity. If you use the Holiday version, which you have to click on when you go to the Alcon toric calculator. But I think Aura, as I mentioned before, kind of takes into account everything. So you're getting really the true ocular astigmatism, not just corneal, not just from incisions or induced astigmatic changes. So you really get the whole picture of the whole eye, and that adds that extra level of precision for a really outstanding outcome.
Yeah, we agree. today the results are very, very impressive.
Yes.
Any other questions?
I would like to ask you, Roberto, and the rest of the panel, and just as a disclaimer, we don't do this here yet, but regarding the articles that were presented, what's the stance or discussion in the US regarding bilateral surgery, simultaneous bilateral?
Yes. So, that is actually becoming more performed here in the US. So, basically it's being done in centers where they're doing basically in-office cataract surgery. So it's a room that's been kind of designated in the office for cataract surgery. And so this is another controversial issue here in the US, as well as bilateral surgery. And, I think most of us in the US are not, have not made the jump, even though there's some publications from Canada, talking about its safety as such. There may be, financial benefits and issues for patients, but in general, I think most of us still feel it's better to perform sequential cataract surgery, treat one eye, wait, make sure the first eye is okay before proceeding to the second eye. Myself, the only time that I've performed bilateral cataract surgery is in patients who, had to be under general anesthesia or high risk, could not have anesthesia again, or considered too high risk. And we did both eyes at the same time. But I've done that, I think, twice in my career. So I'm not advocating that. I certainly think as our young surgeons come up through their professional careers, I'm not to jump to that as the best treatment for patients quite yet. I don't think we have enough data. I think there's still a risk of complications that would be problematic yet, but it's definitely being discussed in the US. Great discussion, great topics. I always like being part of this group because we're talking about very important things here that we all can learn from and improve ourselves professionally.
Just telling something that happened today. When Dr. Walton started the surgery, the energy, we have a cut-off energy here, and we started to use.
We had a blackout.
It was with emotion, right?
Yeah.
So
that's why we took a little while to connect something.
But everything was very, very good, and I think the surgery is perfect, and your organization, Takashi, is perfect.
we have a big collaboration here with the Ophthalmo University, and I would like them to comment a little bit. Benati, Lisandro, and Andres as well.
Also, Ivo, if you can show, this is the Faco Club here in Brasília. And this happens every month. It's been almost on for 10 years now. And if you can show again your campus where you set up.
For sure. You really, this is very true. This is your house. This is your home here in Mexico City. And I'm gonna go fast. Let me go fast. For example, I have right now, I have Pedro, an amazing colleague from Ecuador, who is training here with us with the simulator.
Good afternoon.
do some procedure there, Pedro. So the virtual simulator, for those who don't know it, you probably know you have Latino Pharma there, providing that amazing technology, and I have seen Takashi and Jonathan Lake talking about it and teaching without it. I recommend everybody when they're doing the first steps or they're learning a new technique to have that amazing amazing technology to learn better. I'm gonna move a little bit fast. There is the best situation room for Dr. Pineda. We're inviting him to come. Look at that. You have the entire Alcon refractive suite, femtosecond, an excimer with Allegro, an oculizer. So basically you can simulate here refractive surgery as well. This is like a hybrid classroom. We're seeing what Pedro is doing in the simulator. And here, it's a very interesting room here. If you can see, look at that. Couple of screens, a little bit of technology, but everything for teaching, right? We have the Bionico models there. And think about it. We have right there, I hope you can see it. We have Varion for people to do a better incision, better capsulorhexis. We put toric IOLs, you can align them, everything that Dr. Walter nos said, that I want to congratulate for the amazing surgery. We can do it here in a simulated environment. So that's going to be better. Look at that. Actually, you guys are right there, in the big screen. So you can see colleagues from all over the world. And then you have the eye there. We actually are doing a lot of stuff with Active Sentry. I don't know if you already have it there in Brazil, but we are doing amazing things, especially lowering IOPs to 20, what we call, doing Faco with physiological IOPs. Very, very interesting, amazing results in the post-op. You have Ingenuity, and let's go because we need to simulate everything. So we really like to simulate even the consults. The magic happens in the ophthalmology consults. We have here a couple of good friends having tested the dry eye. I don't know if you know it. I don't know how it's in New York or in Brazil, but dry eye here is like 80% of our patients have dry eye. We have a slit lamp, all the suite from Nidec. Here we have 2 more rooms. So again, the idea here is not to show off. The idea is for you to understand that this is your second home and you're welcome to visit in Mexico City. That's what we're doing here, Jonathan.
No, excellent. Magela, can you comment? Pode falar em português, Magela?
Okay, I can try speaking English. Unfortunately, I couldn't get connected in time. I got connected a little bit late. But for me, the greatest problem of toric IOL is the rotation after the surgery. I'd like to ask Dr. Walton, is there any preventive measure to avoid that?
Geraldo.
A rotação após a cirurgia, Walton, que muitas vezes ocorre com a lente histórica.
The problem is not the rotation itself, is the kind of the lens. Some lens rotates more than others. So the lens we just put has a very little rotation by the literature. Other lens has counterclockwise rotation and clockwise rotation, and also the sulcoflex for toric sulcoflex is not so good. The rotation is very high. I think it depends more from the platform than and the eye a little bit. How big is the capsule or the bag?
A good capsule. Okay.
Good capsule.
But is there any preventive measure you take, or if you use on this kind of lens you just mentioned?
Yeah,
to avoid that.
we have to use the lens we have. We can do much work on those lenses to fit it better in the specific bag. Unfortunately.
Olha, vou falar em português aqui. Tem um trabalho que está saindo esse mês do George Warren, que é um super amigo nosso, né? Dos brasileiros, né? Ele participou agora no CBO e apresentou para a gente de volume do cristalino e idade. Então, é um trabalho elegante e bem desenhado, mas me parece que com essa linha que ele está abrindo de estudo de volume do cristalino ao longo da idade e de tamanho, né, de cápsula, etc., talvez a gente possa prever situações
não deixar o
de
cristalino
rotação
crescer demais.
Bom,
ou
isso,
seja,
sem
tirar o
dúvida.
cristalino um pouco mais precoce, porque também... Né,
Interessante, bem interessante.
Não é pra a gente esperar tanto para tirar uma catarata. Eu acho que tem que ser essa conversa mundial e principalmente nacional aqui, para o pessoal dar atenção nisso, porque realmente a dilatação da cápsula, esses cristais são 6 milímetros, 5 milímetros de espessura, faz toda a diferença na posição efetiva da lente depois.
Interessante. Obrigado.
Um abraço,
Prazer em falar com você, Valdo. Tudo de bom.
Um abraço, Magela.
Obrigado.
Prazer em ouvi-lo. Um abraço.
Valeu.
Carabolo.
Oi, Takashi, tá me ouvindo? Tá me ouvindo?
Sim, sim.
Eu só queria fazer um comentário a respeito da cirurgia, sobre a estabilidade da câmara anterior com a incisão do fento segundo. Isso você percebe que quando ele tira a caneta da câmara anterior, não tem aquela anteriorização da cápsula posterior. E isso dá uma segurança enorme, né, para a cirurgia e também, eu acredito que favoreça também os resultados do HORA.
Bem lembrado e bem observado. Realmente faz toda a diferença, mas a gente tem que lembrar também que posição do paciente, os autohipermétropes, que não é o caso dela, é uma baixa hipermétrope. Então, tem vários outros fatores que fazem com que aquela pressão interna faça perder câmara. Mas a incisão é fundamental, realmente, e a paracentese também, né? Você viu uma paracentese que tem pouco vazamento de líquido, e isso com as novas canetas do Centurion com pressão baixa, você vai ter menos essa diferença. Então, você vai deixar a pressão em 20, 30, como o Ivo mostrou agora há pouco, e quando você tirar, vai manter praticamente essa pressão, né? O ruim é quando você sai de 60 e vai para zero, praticamente. Então,
60, 110.
110. Então, bem legal, parabéns.
Beleza.
Ele notou esse detalhe, cara.
Alípio.
Hello. It's really unbelievable the technology that people are using in cataract surgery. It's possible to have some mistakes in the calculator, but the thing is, what we have to have it's very important to tell to the patient the expectation of the patient with the final results. But with those kind of technology, it's very hard to have a bad result. In good hands like you, it's very difficult to have bad results. Congrats.
Thank you. The best thing is about the technology, and that the technology puts everybody at the same level. So I think even the residents, they get to the good level as soon as possible. It's very
the setup
more democratic.
The setup of Dr. Ivo shows that. You can simulate so many situations that the residents will be very fast in good shape. But you have to know how to use the technology also. It's not that easy to use this technology. I just bought the Solix OCT, and we are seeing the size of the lens in some good shape. It's unbelievable. You can see how dense is the cataract. It's something that you can convince the patient. Look, you had this kind of opacities. Now it's worse. So you can convince because one thing is the vision. One thing is the vision, but the quality of the vision is something that you cannot. It's very subjective. The quality of the vision. So those images you can show very easy to the patient and convince them, but always the expectation is against us. So you guys have a level of expectation very high. My patient have another expectation than you. So I never will say that you're gonna be 2020, 2015, never. I always say, I can try to take out your glasses, but I'm not. It's not guaranteed. That's what I use always, because if you go very fast, very high expectation, that's a big problem.
That's important. It's much better for the residents to start doing this, not to put a lot of expectation for those patients. And us also works for everybody. I think we're not against glasses. I said it to my son just performed surgery in my eyes. I wanted to be a very good for distance. I don't care about using glasses. Fortunately, I don't need glass for reading, even for distance. So I'm perfect.
I just want to thank everybody for the time, we need to finish, but I loved your comment, Dr. Alipio, and we don't only need to use the best technology, but we also need to upgrade our own software, right? Our own mindset on how to grab that technology and become better surgeons, better decision makers, and to give, of course, as always, and the most important thing, the best for our patients. So thank you guys so much. It was amazing. It's so easy for us now to have a good lecture and then live surgery. Think about this, guys. 2 years ago, this was like unbelievable. And now we're doing it like regular Monday, right? So again, Takashi, thank you so much. Jonathan, Walton, Guido, Alipio, and of course, Roberto. We enjoy your presence so much and hope to do this again. For me, you know me, Takashi, we could do this every Monday. I have no problem.
Let's do it, Igor. Let's do it.
Let's do it. So have a great week, guys, and hope to see you soon.
For you too, guys. Thank you.
Thank you. Thank you, Ivo.
Roberto, thank you so much for being here. So we've been doing this meeting since February of 2012. This is meeting number 99. Next month will be meeting number 100, which will be a big milestone for the Faco Club here in Brasília, in which we have very high-level clinics, and we rotate in all the clinics here in the city. So this has been very positive for us. We've done a lot of science and a lot of clinical discussions here in all these meetings. Thank you so much for being here with us, and hope to see you in person.
Yes,
Roberto again, but all the rest.
Brascas, Brascas
next May, finally back to normal, hopefully.
Pineda will be here, and everybody will be invited for coming.
Yes, yeah.
Bye-bye.
Thank you, everyone.
Thank you for
Thank you
everybody.
for the invitation. Wonderful program.